My name's Sinead Millwood. I'm a junior doctor currently working on the intensive care unit at Southmead Hospital in Bristol. But last year I worked as a junior doctor at Yeovil District Hospital, where I decided to do a project on making mistakes.
To speak a bit about the background of the project and what prompted me to do it, and then I'll go on to describe the quality improvement process itself. And finally, I'll talk a bit about the impact that the project has had. So I'd just like to start by asking everyone who's listening to ask yourselves a question. Have you ever made a mistake which could have compromised patient safety? It's not an easy thing to admit, especially in front of your peers. One of the things which prompted me to start this project was that I did make a mistake during my second job as a junior doctor. I made an identity error which resulted in the patient receiving an unnecessary transfusion. And whilst this was a near miss, as the patient does not appear to have suffered any harm, I've never felt so awful in my life. I felt ashamed, mistrustful of my ability as a doctor. Unreasonably, I felt that everybody was looking at me and pointing at me, although in reality, nobody knew that I'd made a mistake. And I felt alone. I was concerned that other junior doctors were going through a similar thing, and the fact that nobody was talking about it might mean that patient safety was being compromised. I designed a survey to ask my fellow junior doctors what kinds of mistakes they were making and try and find out a bit about the culture surrounding making mistakes. First, do no harm. I'm sure you'll all recognise this as part of the Hippocratic Oath, one of the foundations of modern medicine, and an oath which most of us took in one form or another when we graduated. Graduating from medical school is a fantastic feeling. You've made it through 5 or 6 years of study. You've passed your exams, you're full of enthusiasm, you think, I'm going to go out there and I'm going to make a difference. And then you start your first job. I asked the junior doctors the same question I just asked you. Have you ever made a mistake that could potentially have compromised patient safety? And 100% of them have. I asked them, how did the realization of making a mistake make you feel? And these were the answers that I got. Incompetent, guilt, like an idiot, sadness, like a bad doctor, awful, very upset that I may have injured a patient, and shame. Dreadful, made myself doubt my ability as a doctor. Awful, sick, afraid, shame. Panic, sheer terror until I found out I had a near miss and the patient was okay. Embarrassed, guilty, stupid and regretful. And now it seems to me like junior doctors are undergoing some kind of grief reaction every time we make a mistake. But making a mistake is a big part of learning, and unfortunately the current model for learning from mistakes means that junior doctors only learn from their own. And they do that in isolation and fear. This has been recognised in the literature as the second victim phenomenon. It's the negative impact that a medical error has on the healthcare worker. And the second victim, the healthcare worker, feels many of the same emotions as the first victim, the patient or the family members. And you can see from that paragraph there that a number of those feelings have been mentioned in my survey from the junior doctors who I worked with last year. So this is by no means something which is limited to Yeovil District Hospital. Has been recognised in the wider medical community. I asked them, who did you discuss your mistake with? And it turns out quite a lot of us discuss with our fellow colleagues, so other F1s or F2s. 44% of us discuss with a senior colleague, like a registrar or sometimes a consultant. Only 13% of us discuss it with our educational supervisor, which is pretty poor considering that's the person who we are supposed to go to when things like this happen. Some of us discuss it with family and friends or other staff members, and sadly one person didn't discuss their mistake with anyone. And can you imagine how alone they must have felt? Barriers to discussing mistakes included shame, fear of judgment, and on closer questioning, Many junior doctors felt that their educational supervisor was not approachable. I wanted to gauge the kinds of mistakes that we were making, and I split them up into areas which I thought would be common. And it turns out they were common, some of them. 69% of us have made an anticoagulation error, an allergy prescribing error, or a different kind of prescribing error. And this is unsurprising because nationally it is recognised that one of the most common errors that junior doctors make is prescribing. A huge 75% of us have made an identity error. Only 25% transfusion error, and happily, only 6% have made an insulin error, and that was picked up before it got to the patient. So cumulatively, over the first 20 weeks of F1, the first 20 weeks of being a junior doctor, we made 736 simple errors, 91 near misses, and 73 adverse events. Most of those were low harm, but unfortunately there were 3 moderate harm and 3 significant harm adverse events that junior doctors were involved in. This may look like a big number to you, but I actually believe this to be an underestimate for 2 reasons. One reason is that 17 out of 21 junior doctors filled out this questionnaire. And the other is that I think it's unlikely for people to over-report their errors. People are much more likely to under-report. So what's the problem? 100% of us make mistakes. It's led to at least 73 adverse events in the first 20 weeks of F1. Are we reporting them? I think I can say for junior doctors, no. Very few junior doctors fill out incident reports. If you ask a room full of doctors, as I have done, if they filled out an incident report, maybe 3 or 4 have. And if you ask them if they've filled out more than 3, most people will put their hand down. If you ask a room full of nurses whether they fill out incident reports, you'll find that every single one of them has. Nurses are leagues ahead of us in their reporting culture, and I don't know why the culture of reporting is so different amongst nurses, but we, as a group, doctors, are not very good at doing it. Are we discussing our errors? As I've said, we discuss them a bit with each other, but we don't discuss them much with our seniors, and there's certainly no formal debrief when you've made a mistake. And if we're not reporting them or discussing them adequately, then how are we going to understand them? How are we going to act to prevent future adverse events? And what I think I've discovered is a culture of fear surrounding the reporting and discussion of mistakes. And it's not just fear of repercussions, it's not just fear of the disappointment or disapproval of your seniors or the judgment that you're a bad doctor. It's fear of yourself. It's fear of admitting to yourself that you could have been responsible for something serious, that you could have caused a patient harm. And I don't think that this culture of fear is unique to junior doctors or Yeovil District Hospital. So what can we do to try to process errors a bit better? How should we be handling medical errors? A study of residents in the USA identified the need for programs to provide structured, meaningful ways for juniors to discuss their errors, to help them cope and forestall negative emotional consequences. They also identified that the ability to cope successfully with errors may be dependent on appropriate reassurance provided by colleagues and supervisors. And I think this is particularly relevant to junior doctors because we don't have the experience to reassure ourselves. I thought that if I made another error, the best thing that would help me would be to sit down with a group of doctors and discuss it, and so that other people would learn from my error, and so that we could try and come up with some ideas to prevent it happening in the future. I asked the junior doctors if they thought this kind of session once a month would be helpful. Most people said yes. One person said no. They thought that it would be like reopening old wounds, thus demonstrating again the psychological impact that making an error has on a junior doctor. So now I'm going to move on and talk a bit about the quality improvement process. Anyone who's done a quality improvement project will probably recognise this diagram, the Plan, Do, Study, Act cycle. What you have to do before you start a quality improvement programme is is to try and answer these three questions. What are we trying to accomplish? Well, for me, my aims for this project were to promote a culture of no blame, to make some recommendations to the clinical governance department in the hospital to try and prevent future errors from happening, and to share learning so that everybody could learn from one person's mistake. The most important thing about quality improvement is that change doesn't necessarily mean improvement, and the only way to measure that is to try and measure the change that you've done. So how will we know that a change is an improvement? Well, if I take each of those aims one by one, I thought promoting a culture of no blame is a very difficult thing to measure. And probably the best thing we could do would be to just get verbal, informal feedback from the junior doctors after the session. In terms of making recommendations to the clinical governance department, I thought the best way to measure that would be to see if any action to improve patient safety actually comes out of those recommendations that we make. And in terms of shared learning, I thought the best way to measure that would be to see if anybody has a change in practice because of something that they learned at these sessions. The last question, what changes can we make that will result in an improvement? I kind of cheated at because I'd already decided that I wanted to do near misses sessions. So the improvement that I wanted to make was to start these sessions. And these are my PDSA cycles. So you make a change, you measure it, and then you act on that. And then you do it again. And you keep driving up the quality of the project in small cycles. And this was perfect for my project because I was going to do it session by session. So my first cycle was the icebreaker. I decided to do a preliminary sort of 30-minute session to confirm interest in a regular session. I anticipated some resistance, partly from the questionnaire, in that there would be some barriers to people discussing their mistakes openly in front of each other. And I thought the best way to tackle that would be to go first and discuss my mistake first, and then ask each person in the room to discuss a mistake they've made in 2 minutes. So I did this at the end of a teaching session. It did take roughly 30 minutes, and it was very good. There was a lot of enthusiasm in the room, lots of stories were told. Most people were keen to start the sessions, and when I looked back on it afterwards, I decided there was a demand for the sessions, but we'd need a lot more time for it. So my action was to go ahead and book my first session. So that's cycle 2. I planned to do the session in mandatory teaching time. We have to attend 70% of our teaching past the year, so I thought this was a good way to make sure we had a good turn up. I decided it would be best to have a consultant present to facilitate the discussion in case any issues arose that needed to be handled by a senior. I aimed for 3 to 4 discussions in the first session, and I thought I'd run it a bit like what I imagine an AA meeting to be like, with a junior doctor coming to the front and saying, "Hello, my name is Sinead, and I made a mistake." And I thought I'd do a mini root cause analysis for each mistake to try and get a good picture of what went wrong and why it went wrong. And then we'd make some recommendations. In reality, the session before had run over, so I only had 40 minutes for the first session, which was not enough. We only had 2 discussions, and whilst it was a good start, there was some timidity in the room. People did feel a bit unsure about opening up in front of each other. I decided, looking back on that session, that the root cause analysis was too complicated. It took up too much time, and it wasn't really gaining anything. We weren't gaining anything from it. I knew that we needed more time, and I needed to think of a way to encourage openness and make the junior doctors feel that they could speak out about what they were going through. So I planned for the next session to have a much more informal discussion and to make sure I had enough time. So that's us in Yeovil last year during one of our sessions. Very happy. So session 2, I decided to try and drum up some enthusiasm by starting the session with a talk, a TED talk by Brian Goldman, who is a physician in the USA who has done a very famous 20-minute TED talk about discussing mistakes. And in fact, two of the junior doctors came up to me before this session and said, I thought the first session was very useful, but what really helped me when I made a mistake was I watched this TED talk. So I thought that's a great way to start the session. We'll use that. Again, I aimed for 3 to 4 discussions, and I decided the junior doctors could sit or stand. It makes no difference to what's actually the content of the session. And we did away with the root cause analysis idea and just focused on making a good recommendations list. I also decided that it would be a good idea to feed back what the clinical governance department's response had been to our previous recommendations, because then the junior doctors would feel that they were being listened to and that it wasn't a wasted exercise. So the session was really good. It was much better than the first one. There was increased enthusiasm in the room. I decided also to present the project to the wider hospital to try and promote this culture of no blame. So my fourth PDSA cycle was the presentation that I did at BigGov. BigGov is the trust-wide clinical governance meeting, which happens every 3 months. And I had quite a large audience from the rest of the trust. I decided to present data about common junior doctor mistakes, which I've already presented to you, and to try and educate the wider hospital about what we were trying to do with the sessions. So I did a 15-minute presentation, and it was very well received. I think somebody said to me it was the only clinical governance presentation which had ever received a round of applause, although I think they may be lying to me about that. And I did feel like it increased the understanding in the hospital of how junior doctors cope with mistakes. The nice thing was that a lot of consultants came up to me afterwards and said, I think you hit the nail on the head with that presentation. Even as consultants, when we make mistakes, we feel exactly the same way that you do. And a few people even said they were interested in attending the sessions and facilitating them. This was a very good idea because my educational supervisor, who was trying to facilitate the sessions, was not able to always make every single one. So I asked the junior doctors to come up with a list of approachable consultants who they felt comfortable talking in front of. And we sent an email out to them and asked them to facilitate future sessions. So we carried on with that format for a few weeks or a few months. And then I decided to trial a different approach. Problem-based learning is quite a reasonably new way of learning, but it's a lot of the new medical schools use it. My medical school, Whole York Medical School, was a problem-based learning system. And I thought that it would be a good way to approach the sessions. Also, I was speaking to one of my friends in Liverpool, and she said that they'd come up with a similar session there, where the SHOs directed this meeting at the junior doctors. And what they did was they made a certificate for the junior doctor who talked about a mistake, which they could then upload onto their e-portfolio. So I thought I would come up with a certificate, and then we would fill it out during the session using the CBL approach. Another thing which happened at this time, which was very good, was that previously all of the flow of information had been from the junior doctors to the clinical governance department. I was making recommendations to them. But around this time, they started sending information back our way. So we trialed this new approach. When you do a PBL session, you need one chair or the lead person who sort of leads the session and moves the conversation on, one scribe to fill out the certificates, and the consultant to facilitate. In that session, our first one, we only discussed 2 mistakes, and I think that was partly because it was something new and required a bit of getting used to. Looking back on that session, I saw that it was good for the juniors to have recognition and some evidence of their openness and honesty, something concrete that they could keep. And the other good thing about the PBL approach was that it formalised the junior-led discussion. It made it so that it would always be led by a junior doctor, which I think is very important for the success of these sessions. So my action from this PDSA cycle was continue this format, and this is the format which is currently occurring. For the finished product, meetings are 1 to 2 hours, 2 hours if you can get 2 hours, once a month during mandatory teaching time, with one junior doctor to chair the session, one scribe to complete the certificates, and a consultant to facilitate and offer advice. The only stipulation for the consultant is that we ask them to start the session by describing a mistake that they have made. This puts the junior doctors at their ease and makes them more willing to speak out in front of a scary senior. Not present at the meeting, we found that it was useful to have 2 people, the consultant patient safety lead in the hospital, who you could feedback any immediate concerns or issues to, and the most important person for me and for this project was our contact in clinical governance, Joe Howard, who was absolutely key to ensuring the success and continuance of this project. So if I go on to speak about the impact of the project, did we manage to promote the culture of no blame? Well, the feedback that I had from the junior doctors was overwhelmingly positive. The juniors found it cathartic, reassuring, but the most important thing is that they felt that by discussing their mistake, they could have prevented somebody else from making the same mistake. They could have prevented a potential adverse event. 100% want to continue the sessions, and there is lots of willingness for further discussion, in that we've now just started a parallel FY2 session. So now there are 2 sessions running, one for the F1s and one for the F2s. One junior doctor put it quite nicely. They said the sessions help to bring down barriers, makes us all realise that every doctor makes mistakes, no matter how good or experienced. So have we made any recommendations to the Clinical Governance Department? We've made so many recommendations that I can't discuss them all right now. I'll just give you a brief overview of a few. To try and combat the allergy prescribing errors, we've recommended red allergy bands. At the moment, they're white with a little red dot on them. It's not very visible. We recommended putting the patient's allergy status at the end of their bed space. We pushed for a redesign of the warfarin charts, and that is something which has been ongoing for the last couple of months with the pharmacy department, the haematologists and the cardiologists, and it's about to be published now. We use in the hospital. We recommended a near-patient INR testing machine, a finger prick machine. We identified a need for teaching, again, on warfarin prescription and also on drug interactions. And those 2 teaching sessions were delivered by the pharmacy department towards the end of the year and have now been incorporated into the induction to the F1s at the hospital. Ultimately, we thought that e-prescribing would be the best way to prevent future mistakes, and that is something which is coming to Yeovil District Hospital in the near future. And we asked for access to GP summaries on admission patients in the emergency department, because a lot of poor prescribing was happening there, which may or may not be poor for patient safety. But if we could have the GP summaries, then a lot of that would be reduced. So have we shared learning? Well, at least half of F1s have changed their practice as a result of something they learned at these sessions, myself included. What's the key to success? Simplicity, and I think this is the key to success for all quality improvement projects. Keep it simple. If you overcomplicate it, people will lose enthusiasm. Keep it simple, keep it straightforward. Getting people in a room and talking about something is not that difficult. Sadly, anonymity is key to the success of these sessions. the NHS is pushing and promoting a culture of no blame. But in reality, that's not the way that the NHS is set up at the moment, and especially within medicine. It's a hierarchy, and doctors feel pressured to be perfect, and making mistakes makes you feel like it's going to affect your future career. Junior doctors are not happy to put their name to a mistake that would be fed back into the system and might go on their record. So at the moment, the key to openness and honesty is sadly that they feel safe in a safe environment where they can talk about their mistakes without being subject to anything further. And the final thing, which I think is really important, is that these sessions are junior-led. And in my experience, the best way to learn is to work it out for yourself. Having the consultant in the room is extremely important because they can guide you and they have a lot of experience to share. But having somebody stand there and tell you what's right and what's wrong and what you should have done and what you should do in the future is not as helpful as the junior doctor working it out for themselves and realising that just being open and honest, discussion and reflection is the best way to deal with a mistake. So why should every trust start near misses? A, they are of a huge benefit to the trust itself. They are an ideas factory. Junior doctors are your frontline people. They're there on the wards. They see the problems. They have ideas about how to improve things, and you need to tap into that. And these sessions are a great way to do that. They have been of huge benefit to individuals, and I'd like to see it benefit many more junior doctors. I've seen some juniors become fearful in these sessions. It's a very difficult thing to talk about a mistake that you've made and the potential for harm that you could have caused. And it's very nice to see the way that all the other junior doctors rally around that person. The sessions actually encompass a huge number of the core competencies of the Foundation Programme curriculum, especially those that are focused towards near misses, quality improvement, and probity. And finally, I think that every trust should start near misses because eventually we want to change the culture of patient safety amongst doctors. And I think we have to start early because those junior doctors are tomorrow's consultants. And if you want the NHS to be open and honest, you need to start doing sessions like this. I'd just like to leave you with two final thoughts. What kind of doctor do we want to train? Transparency and self-improvement are qualities that should be encouraged and rewarded early on in our training, especially with the emerging emphasis on the duty of candour. And these sessions are a good basis and a good platform for us to develop those qualities. We shouldn't fear discussing mistakes. We should fear not discussing them. Thank you for your time. I'd just like to thank Daniel Gibbs, who did the statistics for me, Charlotte Mitchell, who was very supportive through this project and many others, Dr Khan, my previous educational supervisor, for his support, and finally, the most important person, Joe Howard, who is an absolute trooper for patient safety.
Thank you so much, Sinead. That was really interesting.